Just like the skeletal system, our muscles are separated into two major categories. The axial muscles are those of the head, neck, thorax, and abdomen. Appendicular muscles are the ones that move the limbs or appendages. Your textbook provides excellent tables that list the major functional groupings of muscles, their origins, insertions, nerve supply, and action. It also includes diagrams of selected muscles. Please refer to these tables when learning the muscles. I will not go into detail about reciting origins and insertions in this lecture because the information is consolidated in your textbook, but I will present some concepts, generalities, and clinically relevant information. In the next 3 presentations, we will study the major muscle groups of the body. There are 700 skeletal muscles in the human body. Trying to remember all 700 muscles, plus their origins, insertions, and actions, is nearly an impossible task. One of the worst ways of studying the muscles, in my opinion, done, that is to try to rote memorize every muscle individually. If you look at the tables in your textbook, you will see that the muscles of the body are listed in logical groupings. This is because no muscle works totally alone. Because of this arrangement, it is easy to pick out similarities and differences. When you study muscle groups, note the similarities in origin, insertion, action, and nerve innervation. Then look for an odd man out with respect to these criteria within a muscle grouping. It is much easier to memorize what is different in a grouping than everything about each individual muscle in a group. For example, all the muscles of the forearm that flex the wrist, hand, or fingers have a common origin on the medial epicondyle of the humerus, and all but one muscle, the flexor carpi ulnaris, is innervated by the median nerve. Notice that the pronator teres originates on the medial epicondyle and is innervated by the median nerve, but instead of flexing the wrist, it pronates the forearm. Conversely, the extensors are found on the dorsum of the forearm and have their origin on the lateral epicondyle. Other examples include the gluteal muscles, all of which abduct and medially rotate the thigh, except the gluteus maximus, which laterally rotates the thigh. It is much easier to remember the exceptions than to try to memorize each and every separate muscle. This presentation will focus on the axial musculature, beginning with the muscles of the head and neck. There are 2 major categories of muscles that are found associated with the head region. 1, the muscles of facial expression, and 2, muscles of mastication, chewing muscles. The muscles of facial expression are very complex in humans compared to other vertebrates like your cat. These muscles are different from most other muscles of the body because they lie in layers of superficial fascia of the face and scalp, and they insert into the skin or other muscles, not into bones. Thus, they move the skin and not a joint. They are thin and variable in shape. They give us the ability to communicate emotions without words, such as joy, surprise, anger, fear, disgust, etc. The muscles of mastication have their origin and insertions on bones and work to move the mandible for chewing. We will begin with the muscles of facial expression. This lateral view of the muscles of facial expression and mastication show how complex these muscles are. The muscles of facial expression shown here include the orbicularis oculi, the sphincter around the eye, closes the eye, orbicularis oris, the sphincter around the mouth, the nasalis. Levator labii superioris elevates the upper lip. The zygomaticus originates from the zygomatic bone and inserts on the orbicularis oris at the corner of the mouth, the buccinator. Depressor labii inferiors, depressor onguli oris, and the mentalis. Only 2 of the 4 muscles of mastication, the masseter, the largest, and temporalis, are visible in this view. The epicranius is a muscle of the scalp. It has 2 bellies, the frontal and occipital, which are connected by an aponeurosis flat, sheet-like tendon called the galea aponeurotica or epicranial aponeurosis. The frontal belly or frontalis lies superficial to the frontal bone. It inserts on the skin just above orbit eyebrows. It raises the eyebrows surprise and horizontally wrinkles the skin of the forehead. The occipital belly occipitalis has its origin on the occipital and temporal bones and pulls the scalp posteriorly. The corrugator supercilii is a small muscle that draws the eyebrows together and downward. It wrinkles the skin of the forehead as in frowning. The nasalis has its origin on the maxilla and its insertion on the aponeurosis over the nose. It flares the nostrils. The orbits are surrounded by a tripartite having 3 parts muscle called the orbicularis oculi. This muscle is a sphincter and its job is to protect the eyes from bright light and foreign objects. It functions in blinking and squinting and closes the eye. The levator palpebrae superioris has its origin on the lesser wing of the sphenoid bone and inserts on the skin of the upper eyelid. This muscle functions to open the eye. The zygomaticus is a pair of muscles, a major and a minor. They raise the corners of the mouth upward as in smiling. The risorius draws the corner of the lip laterally and tenses the lips. As you can tell from the name, the levator labii superioris raises levator, the upper superioris lip ii. The depressor labii inferioris pulls the lower lip downward, and the depressor anguli oris is an antagonist to the zygomaticus, which means it draws the corners of the mouth down and laterally as when you are sad. The orbicularis oris is a sphincter surrounding the mouth, but it is multilayered with fibers running in multiple directions as well as circularly. This muscle closes, purses, and protrudes the lips as in kissing or whistling. It is also important for forming words in speech. The mentalis, as the name suggests, has its origin on the mandible below the incisors and inserts on the skin of the chin. It protrudes the lower lip and wrinkles the chin. The buccinator trumpet player is the muscle of the cheek. It functions in sucking, blowing, and positions food between the teeth during chewing. The duct of the parotid gland, salivary gland, pierces the buccinator to reach the oral cavity. The platysma is a thin sheet-like muscle that has its origin in the fascia covering, the pectoral muscles, and its insertion on the skin and muscle at the corner of the mouth. I think of it as an accessory pouting muscle because it pulls the lower lip back and down, causing the mouth to sag. It also tenses the skin covering the neck. All the muscles of facial expression are innervated by cranial nerve 7, aptly called the facial nerve, except for the levator palpebrae superioris, which is innervated by cranial nerve 3, the oculomotor. See if you can guess what muscles of facial expression are engaged in these pictures. Sometimes certain conditions, such as viral infections or a stroke affecting one side of the brain, results in paralysis of the muscles of facial expression due to damage to the facial nerve which controls these muscles. If the lesion is due to a viral infection or temporary inflammation, then the recovery rate is good. However, sometimes stroke victims never completely recover and are plagued with unilateral paralysis of the facial muscles. In these pictures, note how one side of the face droops. Not only that, Bell's palsy victims cannot close their eye on the affected side, which may cause the eye to dry out, resulting in permanent damage. They may also suffer from difficulty swallowing and drooling. There are 4 pairs of muscles that are used for biting and chewing mastication. All are innervated by cranial nerve V, the trigeminal nerve. The prime movers of jaw closure are the masseter and temporalis. They both elevate the mandible. The masseter is the strongest muscle of mastication. The temporalis also retracts the mandible and is a synergist to the pterygoids. Side-to-side grinding movements are handled by the medial and lateral pterygoid muscles. Guess what the origins of the pterygoid muscles are. The medial pterygoid aids in elevation of the mandible and assists in side-to-side grinding motions of the jaw. The lateral pterygoid protrudes the mandible as well as functioning in side-to-side jaw movements. All of the muscles of mastication move the jaw at the temporomandibular joint, or TMJ. In general, there are two major categories that muscles working on a particular organ of the body can fall into. One, extrinsic muscles are those that have their origin outside of the organ, but their insertion and action on that organ. And two, intrinsic muscles have both their origin, insertion, and action on the particular organ. The tongue is an organ of the digestive system. The extrinsic muscles of the tongue anchor and move the tongue. The intrinsic muscles of the tongue curl, squeeze, and fold it into different shapes when speaking or chewing. We will consider only the larger extrinsic tongue muscles. All of these muscles are innervated by cranial nerve XII, the hypoglossal nerve. Hint: any word that has the term glossus in it has something to do with the tongue, and words that contain genio are referring to the chin, actually mandible. The genioglossus then has its origin on the internal surface of the mandible and its insertion at the bottom of the tongue and die of the hyoid bone. It functions mainly to protrude the tongue, stick your tongue out. The hyoglossus runs from the hyoid bone to the tongue and depresses the tongue. The styloglossus has its origin on the styloid process of the temporal bone. It retracts the tongue. There are two categories of muscles that are found in the anterior neck region that play a role in swallowing. These are the 1, suprahyoid muscles, which are found above superior to the hyoid bone, and 2, the infrahyoid muscles, which are below the hyoid bone. Collectively, the suprahyoid muscles help to widen the pharynx to receive food when swallowing. They close off the larynx respiratory passageway so food isn't aspirated into the lungs, and they close off the nasal passageways to prevent food from going up into our nasal cavity. The suprahyoid muscles include the 1, digastric equal 2, gastric equal belly, which has an anterior belly that is innervated by cranial nerve V trigeminal and has its origin on the inner surface of the mandibular symphysis. Its posterior belly originates on the mastoid process of the temporal bone and is innervated by cranial nerve 7 facial. Both bellies insert on the hyoid bone. The digastrics elevate the hyoid and larynx attached to the yoid during swallowing and speech, and depress the mandible when the hyoid bone is fixed in position. 2, the stylohyoid is innervated by CN7 and elongates the oral cavity during swallowing. 3, the mylohyoid molar presses the tongue against the oral cavity during swallowing to move food into the throat pharynx. It is controlled by CNV. If you want to feel these muscles in action, place your fingers on your Adam's apple, the large bump on the thyroid cartilage of the larynx, and swallow. 4, the geniohyoid widens the throat for swallowing and is innervated by the first cervical nerve. To feel these muscles at work, put your fingers on your laryngeal prominence, Adam's apple, and swallow. You will feel your larynx rise. With your larynx in the raised position, you cannot breathe because the air passageway is blocked off. The infrahyoid muscles function to lower your larynx back down after the bolus has passed into the esophagus so that you can resume breathing again. The infrahyoid muscles include the sternohyoid, sternothyroid, omohyoid, and thriohyoid, and are innervated by cervical nerves 1 to 3. The pharyngeal constrictor muscles are characterized by fibers that run circularly in the wall of the pharynx. Their collective job is to constrict the pharynx during swallowing, which ensures that the food bolus passes into the esophagus and not into the nasal cavity. After the bolus passes into the larynx, the infrahyoid muscles contract to bring the larynx back into position for swallowing. The neck is divided up into anterior and posterior triangles by the sternocleidomastoid muscle. These triangles represent landmarks of clinical importance. For example, surgical access to the spinal nerves in the neck cervical region is through the posterior triangle. Care must be taken when doing neck surgery because it is easy to damage the spinal root of cranial nerve XI, the accessory nerve. Damage to this nerve can lead to weakness or loss of muscle function, which makes it difficult to rotate the head to the opposite side, or laterally flex the neck to the same side. Other important structures pass through this triangle, such as the external jugular vein and the upper trunk of a plexus of nerves that operate the muscles of the upper limb brachial plexus. The larynx, thyroid gland, and common carotid artery, as well as the external jugular vein, pass through the anterior triangle. The muscles found in the anterior triangle include the suprahyoid and infrahyoid muscles. The posterior triangle includes the splenius, scalenes, omohyoid, and levator scapulae. The deep muscles of the neck and vertebral column function in producing head movements and trunk extension. They have complex origins and insertions, and their actions can be to move the head, neck, thorax, or the pelvic girdle depending upon which group is contracting. Movement of the head is by muscles originating from the axial skeleton. In general, muscles on the anterior or ventral surface of the body function to flex the head, and the antagonistic muscles located on the dorsal surface function to extend or hyperextend the head. Both groups work to rotate the head when working singly. Note: the longissimus capitis and cervicis are part of a much larger mass of deep back muscles called the erector spinae. Previously, we saw that the sternocleidomastoid is a useful superficial anatomical landmark because it divides the structures in the neck into anterior and posterior triangles. The sternocleidomastoid is a two-headed muscle with its origins on the sternum and clavicle and insertion on the mastoid process of the temporal bone. This muscle is the prime mover of head flexion when both sides contract at the same time. It also moves the head from side to side when only one side contracts. It tilts the head to the side that's contracting. Deep to the sternocleidomastoid are the scalenes, which are muscles of the posterior triangle and have their origins on the transverse processes of the cervical vertebrae. The scalene group of muscles have their origins on the transverse processes of the cervical vertebrae and their insertion of the first and second ribs. The anterior scalene muscles are superficial to the middle and posterior scalenes when the body is viewed from the anterior. The middle scalene muscles are the longest of the three, and the posterior scalenes are the smallest. Working together, these muscles flex, laterally flex, and rotate the head. They also can function in forced or deep breathing. By pulling the ribs toward the head, the volume of the thoracic cavity is increased, thus assisting with forced inspiration. Forced breathing occurs when exercising or under pathological conditions involving diseases of the lungs. In addition to the scalenes, two other muscles flex the neck and head. These are the longus capitis and longus colli. They are deep muscles of the anterior triangle. The origin of the longus capitis is from the transverse processes of the cervical vertebrae, and its insertion is on the occipital bone at the base of the skull. Working together, the longus capitis muscles act to flex the head. The longus colli muscles have their origin from the bodies of cervical and superior thoracic vertebrae. These muscles also act to flex the head. The longissimus capitis is the superior part of a huge muscle mass called the erector spinae that parallels the longitudinal axis of the body on either side of the vertebral column. The origin of the longissimus capitis is from the transverse processes of T1, T4, and the insertion is on the mastoid process of the temporal bone. When both sides contract together, the longissimus capitis extends the head. When one side contracts, the head is rotated so that the face is facing the same side of the contracting muscle. Extension of the trunk is controlled in part by the deep or intrinsic muscles of the back. Intrinsic muscles are those that have their origins and insertions within the vertebral column, as opposed to extrinsic muscles, which may have their origins on the vertebrae, but their insertions on the shoulder girdle and upper limbs. For example, extrinsic muscles would include the superficial muscles of the back, such as the trapezius. The largest of the deep, intrinsic back muscles is the erector spinae. It is a thick column of muscle that extends from the sacrum to the skull and is comprised of many muscles of varying length. Each individual muscle works like a thin rope that when pulled causes one or several vertebrae to extend or to rotate on the vertebrae below. Because the origins and insertions of the muscle groups overlap, entire regions of the vertebral column can be moved simultaneously and smoothly. When all the erector spinae muscles contract together, they extend or hyperex, and the vertebral column. When only one side contracts, the trunk, neck, or head move laterally toward the contracting side. The movement is accomplished because the articular facets of the vertebrae glide on each other. This slide shows the relationship of the multifidus and rotatories of the transversospinalis and two other intersegmental groups. The interspinals, which run from spinous process to spinous process of the vertebrae, and the intertransversarii, which connect the transverse processes of adjacent vertebrae. The primary function of these segmental muscles is to stabilize the vertebral column during movement, preventing the vertebrae from slipping off their articular facets when the larger muscles of trunk contract. The deep muscles of the thorax function in breathing. The external intercostal muscles are the most superficial and function along with the diaphragm in inspiration. They function to lift the rib cage, making it larger in the anterior to posterior and side to side dimensions. The internal intercostals form the deeper layer and aid in forced expiration by depressing the rib cage, make it smaller. Recall that the diaphragm is the muscular partition that divides the superior thoracic cavity from the inferior abdominopelvic cavity. When the diaphragm is relaxed between inhalations, it forms a parachute or umbrella-like dome that covers the inferior surface of the rib cage and sternum, costal cartilages of the last 6 ribs and lumbar vertebrae. When stimulated to contract by the phrenic nerve, the dome flattens, thereby increasing the volume of the thoracic cavity. The resulting negative pressure is enough to suck air into the lungs. The origin of the diaphragm is on the inferior border of rib cage and sternum, costal cartilages of last 6 ribs and lumbar vertebrae. It inserts on the central tendon of the diaphragm, which is continuous with the fibrous pericardium in the thorax. In this view, we are looking up at the diaphragm from the abdominopelvic cavity. Notice the opening in the diaphragm for the passage of the aorta, esophagus, and inferior vena cava. The anterior and lateral abdominal wall has no bony protection, only skin fascia, 4 pairs of muscles and their enveloping fascia and aponeuroses protect the abdominopelvic viscera. The muscle include the rectus abdominis, which is the most medial of the muscles, external and internal obliques, which wrap around laterally and join the rectus sheath, and the deep transversus abdominis. The muscle fibers of the external and internal oblique muscles and the transversus abdominis run cross-directionally to one another, which provides strength. The rectus abdominis runs entire length of the abdomen from pubic symphysis origin to xiphoid process insertion of sternum. 3-5 tendinous inscriptions cross the rectus muscles, forming segments. Because the inscriptions are made of collagen fibers, they do not increase in size with exercise. However, the muscle fibers hypertrophy with repetitive use, forming the 6-pack when the abs are well developed. There are individual variatio, ends in the placement and number of inscriptions. The rectus sheath prevents the muscles from protruding anteriorly when the muscles contract. This picture shows the abdominal muscles in lateral view. Note that the external oblique is the largest and most superficial of the 3 lateral muscles. Its fibers run downward and medially, and their aponeurosis turns under inferiorly, forming the inguinal ligament. The origin of the external oblique is on the inferior borders of ribs 5 to 12, and it inserts on the linea alba, pubic tubercle, and iliac crest. The action of the internal oblique is to compress the abdomen, flex the vertebral column, and aid the back muscles in trunk rotation. The internal oblique is the intermediate muscle located between the external oblique and the transversus abdominis. Its origin is from the lumbar fascia, iliac crest, and inguinal ligament. It inserts on the linea alba, pubic crest, costal cartilages. It has the same action as the external oblique. The transversus abdominis is the deepest of the three. Its fibers run horizontally from their origin on the inguinal ligament, iliac crest, lumbar fascia, and costal cartilages to its insertion on the linea alba and pubic crest. Although all the abdominal muscles play a role in compression of the abdomen, the transversus abdominis is the main compressor of the group. This diagram shows a transverse section through the abdominal wall just superior to the iliac crest. Locate the rectus abdominis, external and internal obliques, and the deep transversus abdominis. Notice the common attachment of all the muscles to the rectus sheath. As discussed previously, working together, the muscles of the anterior and lateral abdominal wall function to support and protect the abdominal viscera, as well as promoting lateral flexion and anterior flexion of the vertebral column. The external and internal oblique muscles flex the vertebral column and function with the muscles of the back in trunk rotation and lateral flexion. The obliques and the transversus abdominis in particular all play a role in compression of the abdominal wall. This increases abdominal pressure, the finer things in life, such as urination, defecation, childbirth, vomiting, coughing, screaming, sneezing, burping, and nose blowing. The body functions aren't always pretty, but they're effective.